Hello and welcome to the third part of our videos on imaging anatomy of the pharynx, and this video will be about the oropharynx. The oropharynx is the middle part of the pharynx. It is located behind the oral cavity and it extends from the soft palate, which is part of the oropharynx, to the lingual border, so the side of the epiglottis facing the tongue base, the lingual border of the epiglottis. The epiglottis is not part of the oropharynx. The epiglottis is not part of the pharynx at all. It is part of the larynx, which is maybe not unimportant to keep in mind. The nasopharynx is located above the oropharynx because it is the middle part of the pharynx, and the hypopharynx is located underneath it. So this is all quite easy. And the oropharynx is the middle part, and it serves as a common passageway for food and air to the esophagus, respectively to the larynx, and from the larynx to the trachea and the lungs. The anterior border of the oropharynx, so basically the border between the oral cavity and the oropharynx, is formed by the oropharyngeal isthmus, which is basically the gap you see at the back of your throat when you say ah. So this is a drawing of the oropharyngeal isthmus generated by ChatGPT, and I must say anatomically quite accurate. So the number of teeth is not completely correct, but those are details and they don't jump to the eye, I must say. Let's use this drawing to illustrate the anatomy of the oropharyngeal isthmus and understand the borders between the oral cavity and the oropharynx. So as said, it is the gateway connecting oral cavity with oropharynx, and the superior border is formed by the uvula of the soft palate, the inferior border by the tongue base, more specifically by the circumvallate papillae, and I'm going to talk about those on the next slide. And then the lateral border is formed by the anterior tonsillar pillars. And when we have anterior tonsillar pillars, we also have posterior ones, of course, but more about that later. For now, it suffices to understand the anatomy of the oropharyngeal isthmus. The oropharyngeal isthmus, the inferior border, is by the tongue, more specifically by a recess located behind the circumvallate papillae. We call this recess the terminal sulcus, and the circumvallate papillae are about 8 to 12 large papillae containing taste buds, especially for bitter taste, and which are arranged in some kind of V shape. This drawing is not completely accurate because that V shape has an apex pointing posteriorly, not anteriorly, but the drawing suffices to basically understand the anatomy. And this recess, the terminal sulcus behind the circumvallate papillae, forms or marks the border between the oral tongue, located anteriorly of it, and the tongue base, located posteriorly of it. So the tongue has two components: the oral tongue, located in the oral cavity, and the tongue base, the posterior third, located in the oropharynx. Let's now talk or illustrate the borders of the oropharynx. The anterior border I've shown you, and the anterior border is actually quite clearly visible when you say ah and look in someone's throat, but not clearly visible on sagittal CT images. We have to infer its location, and we do that by drawing a line from the boundary between the hard palate and the soft palate to the tongue base and the hyoid, as I've done on this image. So, okay, you're going to see this on each CT image on this slide, and this marks the oropharyngeal isthmus, or the presumed location of it. Then the superior border of the oropharynx is formed by the soft palate, and the soft palate is part of the oropharynx, as already said. The inferior border is formed by the lingual surface and the tip of the epiglottis, which is not part of the oropharynx. The posterior border is formed by the posterior oropharyngeal wall, and the lateral borders are formed, and here we see the posterior pharyngeal wall on a magnified axial CT image, and the lateral borders are formed by the lateral pharyngeal walls at the level of the tonsillar region. Okay, let's now also examine the borders on somewhat larger images. So this is the soft palate or the superior border. Here we have the epiglottis, and the lingual surface of the suprahyoid epiglottis, so the part located above the hyoid, marks the inferior border. Here we have the oropharyngeal isthmus, the anterior border, and this is the posterior pharyngeal wall. On a coronal image, we can also see part of the soft palate. This is the uvula of the soft palate, and we can even see part of the epiglottis. So now we have an approximation of the superior and inferior border of the oropharynx, and these are the lateral pharyngeal walls of the oropharynx located between the soft palate and the epiglottis. Finally, let's examine the borders on a large axial image. We clearly see the lateral pharyngeal walls, and this is the posterior pharyngeal wall. And this here is the tongue base, which is, as said, part of the oropharynx, not of the oral cavity. From an oncological point of view, the oropharynx is subdivided in specific subsites. Those are the tongue base, we have the soft palate, we have the tonsillar regions, and we have the posterior wall. And I'm now going to discuss the anatomy of these specific subsites in the rest of this presentation. Let's start with the tonsillar region. You've already seen this illustration, and I've told you then that when you have anterior tonsillar pillars, and what are those? These are basically mucosal folds covering a specific muscle, the palatoglossus muscle. When you have anterior tonsillar pillars, you also have posterior tonsillar pillars. And the posterior tonsillar pillars are also mucosal folds covering a specific muscle, namely the palatopharyngeal muscle or the palatopharyngeus muscle. Then we have a fossa between these pillars, which we call the tonsillar fossa. And in the tonsillar fossa, we find lymphoid tissue, the so-called palatine tonsils. And the palatine tonsils, and this is often the case for lymphoid tissue and the pharynx, they can be enlarged or quite prominent in children, but they tend to become smaller and smaller as we age, and we see very little of those anymore in most adults. Let's now try to recognize these specific structures on an axial MRI image. This is an axial T2 weighted image. This is the uvula of the soft palate. So let's remove the coloring. Okay. And next to the uvula, we see two soft tissue structures. These are the palatine tonsils located in the tonsillar fossa. We see an X shape. Yeah, we see these. We see two arms of the letter X going to and from the uvula. What are those? These are the anterior and posterior tonsillar pillars. The anterior tonsillar pillars are, as already said, basically mucosa lining a specific muscle, the palatoglossus muscle, and the palatoglossus muscle goes from the soft palate to the glossus, the tongue, as we can actually see on this image. And the posterior tonsillar pillars are formed by the palatopharyngeus muscle, which go also from the soft palate to the posterior pharyngeal wall, as you can see here. So this all makes sense, doesn't it? Then we have this muscle over here lining the lateral part of the palatine tonsil. What muscle is that? This is the superior, depending on the level you're looking at, could also be the middle, but probably the superior constrictor muscle over here. And this is, and the superior constrictor muscle not only forms the lateral wall of the tonsillar fossa, but also runs in the posterior pharyngeal wall. So this is the superior and or middle constrictor muscle. I magnified this a bit to make it even more clear. I'm going to repeat it completely because that's the best way for you to learn. Well, I don't know if it's the best way for you to learn. It's the best way for me to learn. Once again, we see the uvula, we see the tonsillar fossa, and we see these muscles coursing towards the tongue and the posterior pharynx respectively, and these are the palatoglossus and palatopharyngeal muscle. And once again, here we have the superior constrictor muscle running in the posterior pharyngeal wall and laterally of the tonsillar capsule. Now, this is a structure we can't see, but the palatine tonsils actually have some kind of capsular lining, a hemicapsule lining the lateral wall. And between the muscular layer, so the superior constrictor muscle or middle constrictor muscle, whatever, which is surrounded by fascia, by the way, and the tonsillar hemicapsule, we have a space called the peritonsillar space. Now, despite the fact that we can't really recognize that very small space on images, it is nevertheless, from a pathological point of view, an important space. Why is that? Well, when a person has a tonsillitis complicated by an abscess, we don't call it a tonsillar abscess, we call it a peritonsillar abscess. Ever wonder why? That's because pathologically these abscesses do not arise inside the palatine tonsil, but in the peritonsillar space. Hence the name, hence why I'm illustrating this, despite the fact that, as said, we can't really recognize it on images. What we can recognize, and what I'm going to repeat once again by showing you a magnified axial T1 weighted image with gadolinium and fat saturation or the uvula, we have the tonsillar region with the palatine tonsils, and it's not so nicely visible as on the T2 weighted images, but nevertheless, if we take some trouble, we can recognize this muscle over here, which is the anterior tonsillar pillar with the palatoglossus, and we have this posterior tonsillar pillar over here with the palatopharyngeus. And final image to illustrate the anatomy of the tonsillar region. Once again, we see an axial T2 weighted image with fat sat, the uvula. We see the X formed by the anterior and posterior tonsillar pillar with the palatoglossus and palatopharyngeus lining the palatine tonsil. And on this sagittal T1 weighted image, we can even see this X, well, it's not an X, in the sagittal plane. We can see these muscles in the sagittal plane. So this is off midline. So this is, let's say, the lateral part of the uvula over here. And this muscle coursing towards the posterior pharyngeal wall is the palatopharyngeus, and this one is the palatoglossus. So I think by now the anatomy of the tonsillar region should be clear. Is there something else I want to tell you or show you? Yes, it is this very fine mucosal recess called the glossotonsillar sulcus. And what is the glossotonsillar sulcus? It is a very small mucosal groove located between the base of the tongue and the palatine tonsil. It's actually often not visible or not clearly visible on imaging studies because the mucosa lies completely opposed to one another. Here we can kind of see it because we see some air lining it, but in a lot of cases you can't really see it. So why is it important? Why am I showing this to you? Well, because it's important to understand tumor spread, because by way of this sulcus, a tumor can extend from the oropharynx to the base of the tongue, because it's a mucosal groove or a mucosal sulcus connecting these two structures, or it can spread from the base of the tongue to the oropharynx. And this is important for tumor staging because an oral cavity tumor or an oropharyngeal tumor often or can have different prognosis and treatment strategies. So that's why I'm illustrating it. That's why I believe you should know there is a thing called the glossotonsillar sulcus. And even though we can't see it in normal situations, when you see a large tumor involving both the tongue base and the oropharynx, you know that this tumor has to have spread from either tongue base to oropharynx or the other way around by way of the glossotonsillar sulcus. And when it comes to entities, I believe you should know, without going into detail, because this is about anatomy, not pathology, you should know, or you should not pathologize palatine tonsils that are enlarged as part of normal physiological hyperplasia, as we can often see in children and even adolescents, but which generally disappear with increasing age. So this is something we shouldn't pathologize, and we see like these symmetrical soft tissue structures located in the tonsillar fossa on both sides. And of course, there's a clear difference with oropharyngeal carcinoma, a tumor that We will not see in children, but in adults, generally adults who have a drinking problem and who smoke. And in that case, the tumor or the abnormality will be asymmetrical. And keep in mind that the tonsillar fossa is the most common subsite for oropharyngeal carcinomas. So just like the Rosenmüller fossa and nasopharynx is the predilection site for nasopharyngeal carcinomas, the tonsillar fossa is the most frequent site for oropharyngeal carcinomas. I'm showing you some infectious entities as well involving the tonsillar region. This is a person with, bilateral tonsillitis. In tonsillitis, the tonsils will be enlarged and enhancing. The difference with physiologically enlarged tonsils can sometimes be difficult, but well, you will often have clinical symptoms, of course. And a person with just enlarged palatine tonsils, it's often an incidental finding. In someone receiving a CT for another reason, they will be enlarged and they will have some kind of striated appearance in case of tonsillitis, as we can clearly see in this patient over here. Next stage in a tonsillitis is the development of an abscess, which we call a peritonsillar abscess. And if this infectious process can spread beyond the fascia lining the oropharynx, it can involve the parapharyngeal space, or in this case, the retropharyngeal space. So when evaluating tonsillar infections, know that they always start as tonsillitis, that they can evolve into an abscess, and if the pathological process continues, they can involve other neck spaces, even the retropharyngeal space, which is the worst space, because when the danger space gets involved, your patient has the risk of developing mediastinitis, which is a lethal infectious disease. Let's move on from the tonsillar region to the soft palate. This is the uvula. So once again, when we look inside the throat and of a person and let him or her say ah, we will see this fleshy protrusion hanging in the back. This is an extension of the soft palate, and here we see the anterior and the posterior tonsillar pillars and the tonsillar fossa, but no mysteries there anymore for us. What is the soft palate? Well, the soft palate is basically a soft tissue structure hanging at the back of the hard palate. The hard palate is a bony structure. It forms the superior surface of the oral cavity. And then we have the soft palate, which is a cape-like soft tissue structure attached to it. The uvula is basically a conical extension of the tip of the soft palate, and it is composed of two intrinsic uvular muscles called the uvular muscles. This is a pathological specimen of the soft palate, and what do we see here? Well, it is lined by epithelial cells on the oral cavity or on the oral surface. Those will be what was I going to say? There's a difference between the type of cells you have on the oral surface and the nasal surface. On the nasal surface, we find more respiratory type epithelial cells, while it are more oral cavity-like cells at the oral level. That's not that important right now. So we have epithelial cells lining the soft palate. Then in the submucosa, we have minor salivary glands. So a tumor type that you can encounter in the soft palate is, well, of course, once again, squamous cell carcinoma, when the tumor originates from the epithelial cells, but also minor salivary gland tumors can originate in the soft palate. But the core of the soft palate is basically a group of muscles. So when we look at the core of the soft palate, what do we see? We see muscles which are attached to a central aponeurosis. So the soft palate, if you think about what is that structure exactly, it's basically some kind of muscular fibrous unit. And it is composed of 4 extrinsic muscles and 1 intrinsic muscle. And each of those muscles we've already discussed actually in this presentation and a previous presentation on the nasopharynx. So we have 2 muscles that are associated also with the Eustachian tube, the levator veli palatini muscle, which is responsible for the elevation of the soft palate, and the tensor veli palatini muscle, which is responsible for tension of the aponeurosis of the soft palate. And when these muscles contract, the eustachian tube will also open, as you remember from the presentation on the nasopharynx. And then we have two muscles constituting the anterior and posterior tonsillar pillars, namely the palatopharyngeus and the palatoglossus. Then we have two intrinsic muscles and the uvula called the uvular muscles. Okay, what is the function? So this we already said. So the soft palate is basically a midline aponeurosis with interweaving pairs of muscles. So what is the function of the soft palate or of the muscles in the soft palate? They elevate and tense the soft palate during swallowing and speech, and this closes the nasopharynx during swallowing. So there is no regurgitation of fluid or food from the oral cavity into the nasal cavity. And when we do that, we simultaneously open the eustachian tube and the middle ears get ventilated. This is a patient who received a swallowing examination. This is in rest, and the quality is low because we do that low dose. But this here is the nasopharynx, and we see contrast lining the tongue and the oral cavity, and we see that in normal situation at rest, the soft palate basically borders the tongue and closes off the oral cavity. When we swallow, however, the oral cavity, and then we get, there's a free passageway from the nasal cavity to the pharynx for air. When we swallow, however, we get an elevation of the soft palate, and it makes contact with the posterior pharyngeal wall, closing off the nasal cavity from the oral cavity. And this will allow food and drinks to go from the oral cavity to the esophagus without regurgitation into the nasopharynx. Okay. Let's now examine the anatomy of the soft palate muscles and the coronal plane. So here we have the torus tubarius of the nasopharynx. This is the levator veli palatini muscle, which you remember from the presentation on nasopharyngeal anatomy. And here we see the soft palate. This is another patient, and we see that the levator veli palatini muscles form some kind of sling. So when they contract, they will elevate the soft palate. This is another patient, just for practice purposes. We see the same things, the torus tubarius, we see the levator veli palatini attaching to the uvula and the aponeurosis of the soft palate. We see that there is tissue of the soft palate which has different signal characteristics. This is the non-muscular part of the soft palate. So the soft palate also contains submucosa with a lot of some fatty tissue and some minor salivary glands and so on. So this is that other component. We also see, indicated by the arrows, a very fine dot laterally of the levator veli palatini muscle. This is the tensor veli palatini muscle, which is a lot smaller and more difficult to see than the levator veli palatini muscle. And here we have a muscle coursing from the soft palate to the tongue. This is the palatoglossus muscle. And here, we see the actual tongue indicated in red. And if you look at these structures, you can also recognize an X shape a bit, and we see like the sling-like morphology of the soft palate muscles in the soft palate. This is an axial image, and the morphology of the soft palate is a bit more difficult in axial images because, well, the soft palate slopes downwards, so we're not able to visualize it in one plane in the axial. Here we see part of the tongue, and this tissue located behind it is the soft palate. We can recognize here the uvula. Yeah, we even see these muscular structures. And this is probably the levator veli palatini, or it's going to be the levator veli palatini. And then we have tissue with different signal characteristics. So this is the non-muscular tissue of the soft palate. And you will see, and this can be a bit confusing on actual images on CT on MRI, the soft palate in rest immediately lies against the back of the tongue. So we don't see air between those. So we have like these soft tissue structures lying next to each other, or on top of each other. We have the tongue here, and then the soft palate lying immediately on top of it, sealing off the oral cavity, which can make actual images sometimes a bit more difficult because you don't really understand what you're looking at. Once again, here we see some partial volume of the tongue located against the hard palate. And at the back of it, we see the soft palate, and we can recognize the uvula, which has different signal characteristics, because the uvula is basically composed of two muscular structures, the uvular muscles, and we see the levator veli palatini forming a sling going to the uvula. Okay, and that concludes the soft palate. We're ready to talk about the tongue base now, because as already said, the tongue can be divided in two components. We have the oral tongue located in the oral cavity and the tongue base located in the oropharynx. The tongue base is the posterior third of the tongue. It is the part of the tongue located behind the terminal sulcus and the circumvallate papillae, structures that we cannot recognize on images. So what do? We draw a line from the back of the hard palate to the hyoid bone, and the part located behind that, we say, well, approximately this is the tongue base or the posterior third of the tongue. We also have a recess located behind the tongue base and the lingual surface of the epiglottis called the vallecula. And basically, this is not one recess, these are two recesses, paired recesses, as you can see on this axial image. So we have two of them. So this is the sagittal plane, and we recognize here the epiglottis. And I'm just going to repeat myself. The epiglottis is not part of the pharynx. The epiglottis is part of the larynx. And then we have this recess between the epiglottis and the tongue base. This is the vallecula. And this is part of the oropharynx. So we can consider this part of the tongue base. Here we see the paired vallecula. We see the epiglottis here in yellow. And this small line is called the median glossoepiglottic fold. So it's a bit of tissue connecting the tongue base with the surface of the epiglottis. And here we have the pharyngoepiglottic folds on both sides, connecting the lateral pharyngeal walls at the level of the tongue base with the surface of the epiglottis. And so we get like these two recesses located over here. We can also see it quite clearly on this magnified view. This is the hyoid bone, and the epiglottis actually has two components. We have a suprahyoid part, which is free, and we have a fixed infrahyoid part, as you can see here. And we see here also on the magnified, this magnified view, the glossoepiglottic fold and the pharyngoepiglottic folds. It's not completely visible over here. If we went one slice lower, we would have seen the left fold as well, but I wasn't able to visualize them in the same plane in this patient, and these line both vallecula. What we can often see, especially in younger patients at the level of the tongue base, is this. We see here the tongue base. You will recognize this if you've seen the video on oral cavity anatomy, so I'm not going to repeat these structures, but this here we see tissue. This is not, the tongue is composed of muscles. We see here the typical dark signal of muscular structures. This tissue has different signal characteristics. This is not muscular tongue. What is it? These are the lingual tonsils. So once again, we are dealing with lymphoid tissue, part of Waldeyer's ring that can become hyperplastic, especially in younger patients. And it's very important to not confuse this with pathology. Here we see a patient with lingual tonsil, enlarged lingual tonsils. The patient also has enlarged lymph nodes on the right side of the neck. That was because the patient had a tonsillitis, but this here is not part of a tonsillitis. This is an enlargement of the lingual tonsils, as you can often see in children or younger patients. These are aggregates of lymphoid tissue. They are often symmetrical and enhancing and can give the tongue base a somewhat irregular nodular surface. If you're dealing with children and you see this, this is going to be lingual tonsil enlargements. It can persist in adults, but it is less common there. So there you, especially in older patients who are smokers and drinkers, you have to consider the possibility of tongue-based carcinoma, but most of those will be asymmetrical, but nothing is impossible. So, okay, lingual tonsils, and it brings us to a brief discussion on tongue-based pathology, very short. But what you should take with you after this presentation is do not pathologize lingual tonsil hypertrophy, which is symmetrical and more commonly seen in children. Do not mistake that for tongue-based carcinomas, which are often, well, you have a different patient group, older patients, smokers, drinkers, often asymmetrical. The tongue base is the second most common subsite for oropharyngeal carcinoma after the tonsillar region. And you can also have tumors in the vallecula, which can be considered part of the tongue base. The difficulty with a tumor in the vallecula, as we see here, so this is the normal vallecula, and this is a vallecula completely obliterated by enhancing tissue because there's a tumor there. That's, well, what's the origin of the tumor? If the tumor originates from the base of the tongue, you're dealing with an oropharyngeal tumor. If the origin is the epiglottis, which is theoretically possible, we are dealing with a supraglottic laryngeal tumor. In this case, I would feel inclined to say this is going to be a tongue-based tumor, completely obliterating the vallecula, but it can be very difficult and sometimes more a distinction based on gut feeling than hard arguments. Then finally, the last subsite of the oropharynx, the posterior pharyngeal wall. When discussing the tonsillar region, I told you that the lateral wall of the tonsillar fossa is formed by the superior constrictor muscle, and this muscle continues in the posterior pharyngeal wall. So this is basically a wall composed of interweaving fibers of the superior and middle pharyngeal constrictor muscles covered by mucosa. And this muscle, as we have seen in the first presentation on the pharynx, is necessary for swallowing and propels food from the oral cavity or the oropharynx into the hypopharynx and esophagus. And normally it's very, very smooth and thin. As you can see on these extremely magnified images, this is the posterior oropharyngeal wall. So a very thin T2 hypointense layer covered by mucosa. And this is on a sagittal T1 weighted image, so we see a very thin layer of tissue over here. Tumors here or, well, it's the least frequently involved subsite for oropharyngeal tumors, but not impossible. So if you see this was a squamous cell carcinoma arising from the posterior pharyngeal wall. Because tumors are very uncommon there and well, all tumors start small, they can easily be missed if you do not look for them. So always give the posterior pharyngeal wall a glance when interpreting a CT of the head and neck or an MRI. And with that, I think we're ready for the final part of our discussion on imaging anatomy of the pharynx. Let's now talk about hypopharyngeal anatomy.